Intellectual disability is a limitation in general mental abilities that affect the individual's intellectual and adaptive functioning. It is the most common type of intellectual disorder, and it usually takes effect prior to age 18 years and affect about 1% of the general population. Onset of deficits and impairments begins during the developmental period of infancy or childhood. It is classified based on its level of severity in that it may be mild, moderate, or profound. The causes may be hereditary. It may be a disruption in the embryonic development. It may be due to pregnancy and perinatal problems, medical conditions, trauma, and poisoning or sociocultural.
Intellectual disability is usually diagnosed through intellectual and adaptive functioning. The level of severity is based on deficits in adaptive functioning. Therefore, it is critical to assess and focus on the client's strengths and weaknesses. Intellectual functioning includes the mental ability to reason, to solve problems, use judgment, abstract thinking, academic learning, and learning through experience. To make a diagnosis of the condition, there needs to be deficits in these areas. Adaptive functioning are deficits that results in failure to meet developmental and sociocultural standards for personal independence and social responsibility. Without ongoing support, the adaptive deficits limit functioning in one or more activities of daily life. For example, communication, social participation, and independent living across multiple environments, such as home, school, work, and community. The onset of intellectual and adaptive deficits during the developmental period is also one of the diagnostic criteria required for making a diagnosis. The levels of intellectual disabilities ranges from mild to profound. On this slide, you will see that the numbers in parentheses indicates the IQ level of the individual. Autism is a neurological disorder in children characterized by the presence of severe communication, social and language deficits, emotional detachment, excessive rigidity, and withdrawal into self and into a fantasy world of his or her own creation. It is a neurological and developmental disability that usually show up during the first 3 years of life. Autism ranges from mild to moderate to severe. It can cause major impairment daily. A diagnosis of autism can only be made if specific social interaction, communication, and behavioral deficits are present. The DSM places Asperger's syndrome at the highest end of functioning of the autism spectrum category. Asperger's is sometimes confused with ADHD. The child with Asperger's usually do not have language development delays, but have difficulty picking up on social cues and lack social skills. They have trouble interpreting verbal and nonverbal signs. They often take abstract comments literally and lacks empathy. Autism can be diagnosed at any age, but the symptoms usually occur between ages 2 to 3 and it may go unrecognized. These symptoms are persistent and interferes with daily living. Impairment in communication and social interaction, restricted interest and repetitive behaviors are the core symptoms of autism. The autistic patient has social skills deficit, and so they will avoid eye contact or make very little eye contact. They prefer to play alone, and this is a failure to develop cooperative and imaginative play. They have a flat facial expression and often do not react to others' attempts at interaction. They fail to or they are slow to respond to someone's calling, and they do not respond to their name before 12 months of age, and they have difference They have, indifference to affection and physical contact. As toddlers, they are either seriously attached to a significant person or not. The communication deficit includes delayed speech and language skills, echolalia, incorrect use of words, nonverbal expressions that is missing or inappropriate. They talk in a flat robot-like voice and are unable to understand jokes, sarcasms, or teasing, use of facial expressions, and they'll give unrelated response to questions and uses few or no gestures. They have difficulty with the back and forth of a conversation. They have repetitive and restrictive behavior and routine. These include repeated words or phrases like we said, echolalia. They are overly focused on moving objects or part of the object, and they display distress if there's changes in their environment or routine. They are sensitive to light, noise, clothing, or temperature. They have repetitive motions and spins in circles and play with toys the same way every time. Other symptoms include unusual eating habits, aggression, self-injury such as head banging or biting of the hand or arm, impulsivity, hyperactivity, and unusual reaction to the way things sound, smell, look, taste, or feel. Other repetitive body movement includes hand flicking, rocking back and forth, or body swaying. The autistic person has many strengths, such as being visual and auditory learners. They're excellent in math, science, music, and art. They may also have the ability to remember information for a long time and to learn things in detail. The physical, psychological, and social context should be determined when assessing the child with autism. You should first determine if the child is reaching their developmental milestone for their age. If they are, you should determine in what areas of development are they meeting these milestones. You want to assess for the quality relationship between the caregiver and the child. Is there appropriate bonding between caregiver and child? Is there tension between the caregiver and the child? Is the child able to interact with others their own age? Be aware that the child with developmental disabilities are at risk for being abused. Therefore, it's important to monitor for safety. The abuse they face is usually because the caregiver is unable to handle the strain of dealing with the deficit the child is experiencing. So you will assess for co-occurring conditions with intellectual disorders, as this may be present with the lowest functioning person. Assess for the child's strength because the long-term outcome is for the child to reach their fullest potential. Be supportive. Is the child able to communicate verbally and non-verbally? Or can they interpret social cues, and does the child become affected if changes are made in their environment? Or do they show attachment or extreme fascination with moving objects? In order for the child to reach their full potential, it is important to foster developmental competencies and coping skills. You want the child to have an increased interest in interaction and be able to move from being alone to being able to interact with other children. You want to promote the development of social skills by moving the child to participate in group activities or common activities. The child should be able to express appropriate emotional response and be able to maintain control when things are not going their way. In other words, the child should be able to adapt to changes and respond appropriately. The child should be able to develop trusting relationships and appropriate verbal communication and be able to perform their ADLs, especially in caring for themselves. This should be done age appropriately. The child should be able to develop increased attention and problem-solving skills and to become aware of their body image and their self-esteem. We should help the child to develop self-control and increased tolerance when frustrating situations arise and to respond appropriately in these situations. It is essential to recognize the importance of reinforcing the child's ability to make eye contact. This interpersonal skill is essential to the child's ability to form satisfactory interpersonal relationships. Attention Deficit Hyperactivity Disorder, or ADHD, is a poorly controlled disruptive disorder where the child is acting out and displays impulsive behavior in situations where self-control is expected. These outbursts may be considered as temper tantrums. These individuals are highly distractible and they are unable to refrain from reacting to stimuli. They are constantly restless, always running, jumping, or wiggling. They experience a greater than average number of accidents, which can range from a minor mishap to a major accident that may lead to physical injury or destruction of property. A diagnosis for ADHD is difficult to make in a child younger than 4 years old. It usually occurs before age 12. Symptoms must be present in at least 2 settings, such as the home or school. A diagnosis is not usually made until the child begins school and has difficulty adjusting. Prior to that, the behavior is characteristic of childhood behavior. It is more common in boys than girls by a ratio of 3 to 1, and up to 9% of school-age children are affected by the disorder. Up to 60% of childhood ADHD cases will persist into adulthood. Up to 84% will have a comorbid psychiatric disorder, with 40 to 75% having conduct disorder. The child is typically the class clown. They're intrusive and bothersome and are distractive. Other comorbid conditions that may affect the child with ADHD is oppositional defiant disorder, anxiety, depression, bipolar disorder, and substance abuse. Symptoms of ADHD will include inattention and hyperactivity. These traits contribute to low frustration tolerance, temper outbursts, labile moods, poor school performance, peer rejection, and low self-esteem. Inattention is usually diagnosed at the elementary level. These kids have difficulty controlling their behavior, difficulty in performing age-appropriate tasks, and staying on task because of constantly moving and not being able to stay calm. For hyperactivity, this is continuous movement, including running, jumping, wiggling, and fidgeting. This usually gets the child into accidents, and this could be minor or major accidents to self or property. The inattention and hyperactivity decreases the child's ability to tolerate frustration, and this will become a contributing factor toward temper outbursts and changes in mood, aggressive or oppositional disorder, or Tourette's disorders. Others may display regressive or immature behaviors, with up to 20% becoming depressed. They have difficulty in forming and maintaining interpersonal relationships because of their disorganization and messiness. Poor performance in school and the rejection of peers oftentimes contributes to the child's low self-esteem, and they may experience nighttime or daytime bedwetting or encopresis, which is fecal soiling. When assessing the child with ADHD, you first need to gather information on the onset of the condition and the behavioral symptoms related to the degree of inattention, impulsivity, and hyperactivity. The behavioral symptoms need to be present for at least 6 months in order to make a diagnosis. This is done through interviews with the parent, caregiver, and teachers, and through observation of the child's hyperactivity, their inattention, their level of physical activity and energy level, their level of tolerance, frustration, and how talkative they are, and their inability to complete age-appropriate tasks, follow directions, and control their impulses. Does the child have difficulty forming relationships? Is the child able to participate in a social environment and games with their peers, or do they rather being alone by themselves? Can they participate without becoming frustrated or have an outburst? You want to know how the child behaves in other settings outside the home, example at school. The ADHD child may become very anxious or depressed because of their inability to keep friends or get the chance to participate in activities with them. These kids need to be involved and have social interactions to reduce their risk of becoming depressed. It is important to establish the knowledge level of the parent and the caregiver in regards to ADHD and its related behaviors. Therefore, we need to provide information where it is lacking. Explore with the family how the behavior is affecting the family unit and family life. Is it limiting them from being able to have a normal life? Are there any support system in place for the parent or caregiver or other family members? Do they get the chance to have time for themselves so they can decompress? Providing them with respite care would be helpful. Discuss realistic goals and behaviors with the caregiver, and you should inform them on how to go about setting these goals. An example would be to have the child sit at the dinner table for 2 minutes. You do not want to exceed 2 minutes, as this can be unrealistic for the child. Plan activities for success. The activities should be geared toward their ability to succeed, so they can experience being successful, and in turn, this will provoke a drive and determination to continue to move forward. When planning activities, plan activities that promote success. Activities that the child is unsuccessful in will only cause discouragement and depression in the child. It would be like setting the child up for a goal that they cannot reach. Provide positive recognition and feedback when the child is successful for an activity. Also, provide positive recognition when they make an attempt. For example, if the goal was to sit at a table for 2 minutes and the child was able to sit for 45 seconds or more, there should be some form of positive recognition for getting that far. Provide the parent and caregiver with appropriate support groups within the community or online that they can participate in. You want the parent to have the support in order to gather more knowledge regarding what is going on with their child. The stresses that comes with caring for a child with ADHD can cause a child to reach their breaking point. Therefore, the implementation of coping strategies is important for the safety of the child and the welfare of the caregiver, and how we can assist with this coping. It is essential that the parent or caregiver has the ability to discuss the child's need and have a plan to provide the necessary support. For example, providing them with respite care, providing them with information on a care group or a support group that can provide support they can use to socialize with. Is there a way for the parent to get away so that someone else can care for the child? It is important that the family is provided with the necessary information related to the child's care. There are cases where you will see the parent become very involved in caring for the child and learn about what is the most current and available treatment about the condition. This can be a difficult situation, however, it can be rewarding for the parent when they see their child reaching major milestones. The first line of treatment for ADHD are stimulants such as amphetamines, which includes Vyvanse and Adderall, and the methylphenidates, which includes Ritalin, Focalin, and Concerta. These drugs produce a CNS and respiratory stimulation, a dilated pupil, mental awareness, increased motor activity, a diminished sense of fatigue, and a good mood. Non-stimulants will include Strattera, Wellbutrin, and Ketopress. Patient may also be treated with clonidine or Tenex. Tourette's disorder is the most serious tic disorder involving both motor and verbal tics. Motor tics may involve the head, the torso, the upper and lower limbs. They may be transient, meaning they appear simultaneously or at different periods during the illness. The disorder is in response to being under stress or excitement, fatigue, or anxiety, for example, the first day of school for a child. The symptoms causes marked distress, or it may interfere with social or other important areas of functioning. The onset of the disorder is usually as early as 2 years old, but is most commonly occurring by age 6 or 7 and is most common in boys than girls. It may be a lifelong condition, but symptoms usually diminish during adolescence and adulthood and may disappear by early adulthood. The first symptom may begin with a single motor tic such as excessive blinking. Simple tic may include eye blinking, neck jerking, shoulder shrugging, or facial grimacing. Complex motor tic may include squatting, hopping, skipping, retracing steps, tapping, or twirling when walking. The child may display uncontrollable gestures such as imitating someone else's movements, or they may exhibit vocal tics such as barks, grunts, clicks, yelps, snorts, sniffs, or they may utter obscenities. The vocalization and movements are typically experienced as compulsive, but it can be suppressed for varying lengths of time and is completely suppressed during sleeping. These children do not choose to tic, it just happens, and they have no control over it. Symptoms of Tourette's are evident when observing a child with the condition. The child will become self-conscious and aware of their tics. They may limit their activities out of fear of not having any friends or anyone to hang out with them if they're barking or yelping or clicking. They may be rejected by their peers, and that will in turn cause them to become depressed. If the child has comorbid conditions such as ADHD, stimulants such as Ritalin will only cause an increase in the tics, and so this will require close monitoring of their medications. Tics cannot be cured. It may go away as the child grows older. The main goal of treating Tourette's is to help the child, the family, and the school to understand and cope with the tic behavior. Treatment is usually done on an outpatient basis. Inpatient or day hospitalization would be for evaluation purposes only. The most effective medication for Tourette's is currently clonidine, which treats the coexisting ADHD symptoms as well. These medications are not used in children under age 6, and the goal of intervention is to decrease the child's anxiety and increase their participation in peer and social activity to improve their self-esteem. The child should be observed for feelings of hopelessness and inappropriate interventions. Appropriate interventions should be implemented to ensure their safety and that they don't have any thoughts of suicide or self-harming. Separation anxiety is excess fear or anxiety when separated from an attachment figure. It is not the typical anxiety that occurs when you leave a child at daycare. It is a severe reaction when you leave the vision of a child to step into another room. The condition is common in infants 8 to 14 months and toddlers 3 to 4 years old, and is commonly diagnosed by age 5 or 6, with most children growing out of it. A child or adolescent with separation anxiety will experience extreme anxiety when separated or anticipated separation from their attachment figure. It is more common in girls than in boys. The child with separation anxiety disorder may display an unrealistic worry that is consistent. They will begin to worry when they suspect or feel that separation is near. Regardless of the type of separation, they will become extremely anxious. This level of anxiety may cause the child to wet the bed, or they will refuse to go to sleep alone unless they are near to the parent or the caregiver or the attachment figure. Separation anxiety may be influenced by the parent, in that the more apprehensive the parent or the caregiver is, the more anxious the child will be. The child may experience nightmares about separation from their parent or primary attachment figure. They may have fears about being left alone and exhibit temper tantrums, and they will be pleading with that attachment figure. The condition may be related with trauma or a stressful situation in the child's life. When assessing for separation anxiety, we need to determine what the child's response were previously to being separated and what is their current response to being separated. Are there any evidence of regression in the child, and are they doing any better now than they were previously? We also need to determine if the child had experienced any traumatic event, and how are the parent? Are they experiencing any anxiety? Is the child a perfectionist? Are they reluctant to attend school or sleep away from home? Or are they socially skilled around their peer? Or are they afraid of the dark? Look at how both parent and child respond to each other's anxiety. What we know is that the more attention that the child's anxiety is given, the more the behavior will be enforced. We need to observe what happens during a separation from parent and child. Typically, it is usually the parent who is anxious when separated from the child. Oftentimes, the child is okay being away from the parent. Nursing intervention for the child with separation anxiety is to assess the child to reach their full potential while helping them to maintain their anxiety. Help the parent and the child to identify more adaptive ways of coping. You want the child to attend group therapy sessions and provide support for any effort that has been put in place to help the child interact more appropriately with others. It is important to work with the parent so that they'll get an understanding that the child may experience regression, and it is how they accept this regression that is crucial. It is important that we provide positive reinforcement for the child whenever they have reached a goal or whenever they have tried. This is done with the aim of helping the child to boost their self-esteem. Family therapy is one form of therapy that is used to identify family dynamics that are affecting the disruptive behavior. It is important that the child is not separated from the family. It should be family-centered and involve all family members. The parents should be involved in designing and implementing the treatment plan, and also involved in all aspects of the process. Family therapy capitalizes on strength and acceptance of shortcomings and development of insights and improved judgment. It helps to gain and use new information, and also for the development of lasting and satisfactory relationships. Families learn to support each other in these cases. Group therapy provides the opportunity to interact with peers. Group therapy is simple participation and playing for the younger child, a combination of play with talk for the grade schooler and talking and peer development for the adolescent. Group therapy helps the child to learn appropriate behavior from the feedback of their peers, both positive and negative feedback. The child learns to tolerate and accept differences in others, to offer and receive support from others, and learn that it is okay to disagree. The child will also get a chance to practice new skills and learn from the experiences of others in a safe environment. Behavioral therapy is a common and effective treatment for disruptive behavior. It is based on a principle that rewarded behavior will be repeated. The child is rewarded for developmentally appropriate behavior. Basically, if the child acts appropriately, they will be rewarded, and that will motivate them to continue appropriate behavior again. It's important to be consistent. Rewards should be withheld when behaviors are disruptive or inappropriate. Cognitive behavioral therapy helps to change both cognitive process and behaviors. It reduces the frequency of maladaptive behaviors and replaces them with new competencies. Cognitive therapy can be individual or in a group. The therapy teaches how to cope with problems through the use of positive affirmation, role playing social skills, assertiveness, along with relaxation techniques. Other type of therapy may include music therapy, with which the client expresses their feelings through music. There is art therapy, which allows the individual to express um, through artistic means, and this type helps the child to spontaneously express themselves, trying to capture their thoughts and feelings that they may not be able to express verbally. Play therapy is also another one that is used. It is the choice for 3 to 9 year olds. And they say play is the work of childhood. So, what toys are used? Several toys allow the child to act out conflicts and stressful situations and work through feelings with the help of the therapist, who can help them develop better coping or better ways of coping. Now, medication should never be the sole method of treatment. It is undeniably that medication can and does improve quality of life for families of children and adolescents with these disorders. However, research has indicated that medication alone is not as effective as a combination of medication and psychosocial therapy. It is important for families to understand that there is no way to just give him a pill and make him well. The importance of the psychosocial therapies cannot be overstressed. It is important. SSRIs and benzodiazepines may be used to help during the early stages of treatment for these disorders.